Azizi Seixas. I'm assistant professor for population health and psychiatry at NYU Langone Health. I'm a behavioral scientist by training, and my work focuses on sleep disorders, particularly looking at determinants of sleep, specifically obstructive sleep apnea, and seeing how we can find creative solutions to actually stave off health disparities among hard-to-reach communities. Our work is engagement and empowerment, right? Those are the two fundamental cores of our work. We engage participants, particularly hard-to-reach participants and patients. This is key because oftentimes there's this misunderstanding that patients or participants don't know what's good for them, but if you engage them, then you will find that the treatment continuum and trajectory would be a very prosperous one and very successful one. Also in terms of empowerment, if you empower individuals, right, then your job as a physician or a provider is going to be minimized, whereby that patient is going to come to you or they're going to seek the necessary resources so that they can be more compliant, adherent, and if there are complications that need to be addressed immediately, then that will be addressed. And so that's primarily the two fundamental core values of our work. And we believe that through that we'll be able to reduce health disparities. What we find, especially in racial ethnic minorities here in New York, that quite a lot of individuals are at risk for sleep apnea. Are unaware of it, particularly because there is this kind of a myth about what sleep is. Oftentimes people associate snoring as well as other forms of classic sleep disorder behavior as good sleep. So the approach that we use is a multi-pronged approach in terms of changing behavior and demystifying what sleep disorders are. So initially what we've done is that we've actually educated people in the healthcare profession to actually have greater contact, because what we've found is that oftentimes part of the reason why we have so much of a misdiagnosis and underdiagnosis of sleep disorders is because most healthcare professionals aren't well versed in what are the telltale signs of a significant sleep disorder such as sleep apnea or insomnia. We've helped individuals to, one, recognize and raise their level of understanding as to what's good sleep and what's not good sleep. And also, when we have provided that level of education where individuals understand and recognize what bad sleep is, then it really starts a trigger process where people say, well, if I'm not getting good sleep, then I am more likely to ask my healthcare provider as to what are some potential remedies. So many people then find this as an opportunity to engage their primary care providers to say, well, do I get a sleeping pill, or are there supplements that I need to engage in, or is there a larger problem such as why is it that I'm on several antihypertensive medications yet they're not as successful? Perhaps there might be some underlying problem such as sleep apnea. What we would like to see is that, and we've been working on this and we've been piloting this, to develop and use more home-based sleep testing. Home-based sleep testing has been fantastic, whereby oftentimes there's some people, because they work one or two jobs, they may not have the time to go to at a sleep clinic. They don't. But what we've found is that we said, no, you're in the comforts of your home. You will sleep normally like how you would normally sleep. And they say, wow, really, you sure? I'm like, absolutely. And they love that. And that level of compliance for assessment has skyrocketed based on what we have seen preliminarily. In addition, what we would like to see in terms of treatment, we would really like much more adjunctive support provided to individuals who get the CPAP machine. Because there is this thing that most people don't recognize, particularly people who are prescribed a sleep apnea. If you're non-adherent, right, within the first 90 days, they're going to take it away. And we've had experiences like that, whereby either the provider did not communicate that well to the participant or the patient, and as a result, they lose it. And so if we were to provide more adjunctive, supportive interventions for patients during those first 90 days, it would lead to long-term adherence where they'll use your CPAP. So what we're currently doing is that we're actually engaging in digital health, mobile health applications that will allow us to provide a similar kind of method, providing the level of contact and support through digital health that we will allow us to actually reach people at a greater level with greater penetration. And so peer health education as well as mobile health education is a method, two methods rather, that we have used, and they've proved to be quite successful. Because one is we're engaging the community, and so we find trusted messengers in the community, either the pastor or people in the health ministry. We've gone to mosques, we've gone all over. We go to the barber shops. People listen to their barbers much more than their doctors. People listen to their stylists much more than their doctors. And we've found that as a good thing. But we also recognize that in the world of this digital explosion, that people are more likely to get their information from their cell phones.
Really fascinating.
Well, thank you. We're trying. It's tough. It's tough, but it's worthwhile work.